afternoon to everyone. Here in this presentation, I'm going to talk about health data interoperability. So I'm a computer scientist at the University of Trento. I've worked on interoperability in general and semantics for last 10 years or so. This talk in particular will be about health data. So I think most of you know very well why interoperability for health data is important. So I don't need to talk about that a lot. I will try to go quickly first. I'd like to say a few words about why I think we are not there yet, despite all the efforts and the progress that have been showed so far. And then some innovation ideas that could make this progress faster, based also on our experience in the Interoperate project and in past projects. Okay, so very quickly about the motivations, because this has also been covered in the earlier presentations. So, of course, the movement of patients in countries and in the EU, and citizen empowerment is also an important topic that we are investigating in the Interoperate project in particular. So retrieving one's own health records and keeping it with themselves, managing it. There's also, of course, medical research, where on a national level, a lot of things are happening already in terms of data integration for research. Of course, research sometimes needs to go across the border if larger cohorts are needed or statistically significant data for precision medicine, for example. And of course, there are all the non-medical uses, such as reimbursement, etc. So the current landscape in the EU, we know about it. Heterogeneity is pervasive, and there has been a lot of progress, but uneven progress across the countries, and even within one country, there can be uneven progress across institutions. And the reasons are well known. So one of the hardest problems, of course, is the use of free text, the wide use of free text in the local language, unstructured documents, but also within data structures. There are a lot of snippets of free text in terms of terms, etc. And of course, this is a problem for automation and for any kind of cross-border use. When terms, codes, data schemas are used to represent data, of course, a lot of local conventions are used there and are implicit. Heterogeneity can exist in institutions. And of course, when you are working locally, you leave out a lot of details because they are evident to you. They are evident to everyone working there. But as soon as the data leaves the institution, the context changes. So those implicit data must become explicit. Okay, so what kind of solutions exist? Of course, standards. So that has been the approach for decades and decades. Standards on the terminology level, for coding systems, and also for information models. So there's been reasonable progress in using these, especially for terminologies and coding systems, as we could see from the previous presentations. But of course, you also need supporting technology in order to make the use of standards easier. We have seen this wonderful presentation on terminology servers, and that they are really being used in practice. These are one of the ideas and technologies that everybody has adopted, and it's clear to everyone how useful they are. In terms of data management, data transformations, the use of extract, transform, load tools has become more and more frequent, ETL tools. In terms of tackling natural language text through information extraction tools, this has not been so widespread for quality reasons, at least not in care, somewhat in research, because there the people's lives are not directly in danger of making mistakes. There's only an indirect connection, but it's more often used for non-medical uses, so for accounting or reimbursement. Okay, so why are we not there yet, despite all the progress? So because there's indeed this Achilles against the tortoise situation, where we are really running fast and we are making progress, but somehow the tortoise is always one step ahead of us. So there are a couple of reasons, not just one. So the first one is that adopting standards is just hard. It's a lot of work. A lot of top experts are involved when you need to build a system that is using a standard that is not a trivial standard. And as we know, in healthcare, none of the standards is trivial. On the contrary, they are pretty complex. So, but even if so, let's suppose that everybody's playing the game with the best of intentions. We are all trying to interoperate, communicate. This is not always the case in the industry, but still, let's suppose it's mostly the case. So even then, due to the complexity, everybody will focus on their own most important aspects of the standard, on their particular use cases. And maybe they will cut corners elsewhere for efficiency reasons. So this leads to implementations that diverge always. So this is always the case. This has been the case so far, and this is going to be the case in the future as well, to some extent. My second point is that technology is not enough. So there have been promises of technological advances in the last 20 years. So we mentioned the terminology servers, which is, in my impression, it's a success. The use of ontologies. So ontologies have been introduced about 20 years ago, more or less. They've been also hyped as a way of automating. And of course, they are useful to some extent. But of course, they don't solve the hardest problems, which is how to prepare the data to respect actually the ontologies. And the hype of the last 10 years or so has been artificial intelligence. So this is the topic unto itself. We could do a presentation just on this, of course. So it has been used successfully in healthcare in specific contexts, pretty restrained contexts such as image analysis. In general, it is not widely adopted for many reasons, for the reasons of quality control, the black box problem, and also what I call the garbage in, garbage out problem, which means that unless you really do the upstream work of adapting the artificial intelligence system to the local context, you cannot expect it to work correctly. ETL tools, as I said, are also used for data transformations in healthcare. One thing that is often missing from them is to go down to the level of natural language, so to go deep enough in the transformation of data to understand natural language labels and to be able to do cross-lingual transformations. In general, the health sector is not an early adopter of technology due to the quality requirements and the traceability, explainability requirements that we all know. Another reason is that healthcare is evolving. So the pathologies themselves evolve, right? Like COVID. Our understanding of them, our understanding of the treatments, etc. The local practices evolve, which means that local data models evolve. And on the other hand, the standards evolve as well. So this means that the tortoise is going ahead as well. So we have to catch up. The implementations must always follow the evolution. The work is never fully done. It is not a one-shot work. It is a long-term, never-ending investment, actually. So as a very simple summary, there are some contradicting needs. On the one hand, we have the need of scalability, of course. So we need to automate data mappings and transformations as much as possible because there's a lot of data to be processed. On the other hand, we have a need for correctness. We need to be very precise. We have to be absolutely precise for the care, patient care. In research, as it only affects patients in an indirect way, we can lower a little bit the needs, but still we need we need a very high level of precision. So so this dilemma needs to be solved in some way. And of course, there's no magic solution, and we are not proposing a magic solution. But we have so far working on these issues. We have had some ideas, and so one main idea is that if standards themselves are necessary but not enough, and technology supporting the standards is necessary but not enough, then we need something more. So our point is that we also need methodological innovation to support these. So we have worked on these on healthcare projects where we applied and developed these ideas. I don't have time to present everything now, but this involves the Interoperate project as well, on which we are working, where EHTEL is also a member. And we have also been teaching this methodology in 3 countries: Italy, China, and Ireland. Okay, so what do I mean by deep semantic integration? This means that every single data value that is relevant to the interoperability use case is understood by the system. It is made explicit, and it is represented in a formal language independent manner. So I took this very simple example of a prescription in Italian. So it's a piece of free text in Italian, as it very often appears in health data. And the in-depth understanding of this means that we are able to convert this little piece of text into a knowledge graph where everything is formal. So in my example, this is a fire-based knowledge graph. So of course I chose this simple example so that the image will fit on the screen. But so as you can see here, there's no more free text actually. So we keep the free text, of course, for traceability purposes, but we also compute this fully formal graph that is based on concepts and standard data structures. So once this in-depth understanding is done, the point is then that a second phase of in-depth adaptation is much easier to carry out, and with much less probability of error. So here, there's an example of presenting the prescription in French, as structured data in French. So here, the translation of that formal representation into French data structure is much easier, at least much less error prone than trying to do it in one shot from the original prescription. So this slide is gives you a big picture of the technological components and also the methodology involved. Of course, I don't have time to talk about all the boxes here. That's not important. What is important is to see that on the top you have this workflow starting from the local health data, which goes through these steps of first in-depth understanding, the knowledge graph, and then in-depth adaptation to produce interoperable health data. And of course, it builds on a lot of technological components: information extraction, terminology linking, terminology mapping, language generation, etc. But also at the bottom, you can see that the whole system is configured and adapted to the local context through the use of knowledge. So that's the blue part, which involves terminology, schemas, language models, rules for information extraction, etc. So both the knowledge and the data processing workflow are managed by humans. So there are 2 roles involved here: the knowledge manager and the data manager. Of course, it could be the same person doing both of the roles. So these people are charged with setting up these systems and curating the results and maintaining them over time through the evolution of healthcare data and the healthcare ecosystem in general. But of course, when you so humans are this is one of the important points. The human supervision, human control is essential, especially for patient care. Due to the quality requirements, we don't think that we can do away with human supervision. But of course, then the big problem is how can you supervise? How can humans supervise the process and keep it automated at the same time, keep it scalable? So this is also where the tools and the methodologies come in to make it more streamlined. We are proposing and we have developed a set of knowledge and data management tools that are integrated in a single graphical interface. And I wish I had time to do a demo for you, because we are using these tools already in the interoperate project, and we have managed to map dozens and dozens of data sets from different hospitals using them. And this is also only a screenshot, a small snippet from the tool that we are using, and you can see prescriptions here converted into a fully formal knowledge graph representation. So the basic underlying idea of the tool that you can see here, it is still a kind of an ETL tool. So there's this ETL paradigm, the graphical tool that lets you do the data transformations in an agile way, but it's extended with native multilingual support, semantic operations, and knowledge graph building. And so all the operations of knowledge management and data processing are happening through this graphical interface. All the automated results, such as the results of information extraction, so building a data structure, as you can see here from the left-hand side, free text prescriptions can be manually curated. So the data manager can intervene and correct eventual mistakes. All the input from the data manager is recorded and can be automatically replayed on large data sets. So this is one way of scaling. And then we are doing ongoing research on putting in a learning element where the system actually learns from these human curation activities and improves its automated results, so that less and less curation is needed over time. So in conclusion, some takeaway messages. Full interoperability over health data is hard. It will always be hard. This is just the complexity. Standards as technological innovation are necessary, but not sufficient. Methodological innovation is needed to reconcile the needs for precision, traceability, and automation.
The tools that you've been developing actually can be implemented by all healthcare organizations who actually decide to do so, to do that. Nevertheless, you've been actually more specifically working on certain languages, right? For the sake of interoperate project.
Yes, so in the interoperate project, we have hospitals from 4 countries. So we will have to work with data with all 4 countries. They are so Belgium, Italy, Greece, and Romania. These are 4 languages. Of course, we also have English as a 5th language, because this is the only way we can understand each other. So we have been, so to give one example, we have developed information extraction, high quality information extraction over prescriptions, which you could see on the screenshot. So that was developed for the 2 hospitals from which data we need to process in certain pilots, which was French and Italian. So yes. And in all other aspects of the project, which involved of course the concepts, codes, and their natural language labels. We also included more languages wherever necessary.